So another question, let's say a patient has a surgery, positive margins, positive lymph nodes, gets radiation therapy. How long you will do anti-therapy, hormonal therapy? Are you going for 6 months? Are you going for 2 years?
I think
Are you going longer? And the high PSA, you monitor PSA definitely, but Gleason is high, Gleason 8 or 9.
Gleason is high. I think that is either we call the salvage, is in the salvage setting or is in the adjuvant setting. So salvage setting means when you were monitoring that, it could be 3 months, could be 6 months later, the PSA start going up, you do it. But for your case, sounds like it's more like adjuvant radiation because you already know there is a positive margin you want to do offer radiation. I think for me, I pretty much go by if it's a low or intermediate risk disease, I go by 6 months of ADT, and then for high risk disease, I do 2 years of ADT. That's my approach, but you can always argue majority of the disease is gone. You're only doing a adjuvant setting, so you may not need that. So there's definitely concern of over-treating those type of patients.
Actually, I have a patient who's only early 50s, so he was initially diagnosed with high Gleason score prostate. But they also found when we did the PSMA, there was a spot in the pancreas. And so they did EUS biopsy, and they called it PNET initially.
Wow.
So I sent him to IU actually, and we did Whipple. And then when IU read it, and they said, no, it's metastatic prostate.
That's very rare.
And so, and then we did genetic, and it actually had TMB high and all that. So I have him on Lupron, enzalutamide, and also Keytruda.
Okay.
That's what he's young, he goes, give me everything. He's a police.
Okay.
And then he was like, give me everything. I'm like, give me all you got. I'm like, I'm not ready to go. So I'm like, well, give it all.
That's good. That's a good case. So now let's switch the gear a little bit, talking about the castration-resistant prostate cancer. I think with so many options right now with a castration-sensitive phase, it's a question for us to decide what should we offer to the patient in the castration-resistant phase. Really depends on what the patient what the cancer has been exposed to. So let's say we have options in the castration-resistant phase. Now we have the options of ADT plus ARPI. We have the chemotherapy options. We have the PARP inhibitor options, right? And then we have immunotherapy if the patient have a MSI high, we have that. And then we have don't forget about the immunotherapy, the prevent treatment. I don't know how many of you guys ever done the prevent treatment. Now we have some new data for the radium-223, and then other radiopharmaceutical agent, lutetium-177, Pluvicto. We have a lot of options right now. So do you guys feel like it's challenged in this setting to decide too many data coming in, and how do we move forward? What should we choose to the patient? How to sequence those treatment?
Well, I feel like, right now, since we are giving kind of high intensity upfront treatment in castrate-sensitive setting, assuming, we get a new patient and you're doing triplet or something upfront, then when you come to that castrate-resistant phase, we don't have a lot of options. Because we already used up the options. So then, right now, the radiotheranostics treatment needs to be incorporated sooner than later, assuming you used up your options, right? And you don't have much to offer. So I think that's moving a little early, is the way I feel.
It's definitely changed the landscape of our castration-resistant prostate cancer.
So for me, it's basically my docetaxel, cabazitaxel options, my Pluvicto radium-223. Cipacil T I have probably maybe 5-6 years ago when it really came out. At that point, I've kind of used it, but I think the data wasn't that impressive for me. And the logistics needed to do all that. I kind of moved away from that. So it all kind of, as Dr. Babu said, depends on what I've used in the castrate sensitive and then I try to figure out what data is the best one or what patient fits what criteria or which treatment option that I'll go for that one.
And as Dr. Sadiq said, logistics, it's a big deal too. Whether you treat patients in the office, which is easy to start treatment, to get approval and start treatment as soon as you can, or if you have to send patients somewhere else to radiation oncology, and then you really don't know what's going on and how long it takes them to get approval for Pluvicto, which is, I think, $100,000 one treatment. And sometimes it might take months. And meanwhile, patients goes untreated, and some people even don't come to this point because they might be extremely sick, maybe.
I've been using the Pluvicto way up front now after, because most of them have received Taxotere usually. And so I've been using Pluvicto because as much as I can, I tell the patient that there's really not much options. Once you get past a certain amount, either Pluvicto or cabazitaxel. And usually I want to try and save that as, prolong the period before I have to use cabazitaxel, because once you progress on cabazitaxel, there's really not much unless clinical trial.
And used to be, I think, Pluvicto, when initially was approved, it was approved after docetaxel. But now you can be used even before docetaxel. So it's a big deal. It's a very good drug. It showed survival benefits. Unfortunately, logistics, it's not so simple for us.
The question is, if you are progressing on ARPI, and there's new data with combination, right? ARPI plus Pluvicto in the castrate-resistant. But if you already used up this agent, the only thing that's left is Pluvicto. And if you already used your docetaxel up front, you can reuse it, but you're really running out of options at that point.
Yep, that's the challenge we're facing right now. Interestingly, I read some data actually, although it seems like we have been using the triple therapy, for example, actually, it just I started using this triple therapy probably about 2 years, roughly. There's still a good amount of patients has only been exposed to ADT before they develop castration-resistant prostate cancer. Sure. Surprisingly, I read some data. They say there's about some published coming from, I believe it's UCLA probably. They published about 50%, roughly about 50% of the patients actually still only exposed to ADT. So meaning the ARPI still have a role in this setting, and then the chemotherapy still have a role in this setting. But I agree with you, with the more upfront use of those agents, it did give us challenge backwards to see what should we offer to this castration-resistant phase.
So I have a question. So in a patient who's on ARPI, right, and you give them Pluvicto, are you discontinuing the oral? Or do you continue it while?
It depends whether you think the cancer lost the sensitivity to the ARPI. And then there are some hypotheses think there is a synergistic effect, but I don't think anybody ever proved it. There is a so-called synergistic effect there. So that's just for us to go over discuss some data from recently reported the PEACE 3 trial. So this trial is in the castration-resistant phase. Patient never been exposed to ARPI before. So they compare ARPI enzalutamide plus radium-223 with enzalutamide alone. And then it did show progression-free, radiographic progression-free survival benefit and overall survival benefit. So we're all familiar with radium-223. Back to the old days, not old days. Previously, it's approved by FDA. I use pretty much like a second line, third line for the castration-resistant phase for those symptomatic patients who has bony metastasis. So you should not have a visceral metastasis for those cases. So now they try to move forward using ARPI plus radium-223 for those bony metastatic disease. But of course, you need to put a bone protecting agent in those patients. So what do you think of this type of data? Will this data change your practice down the road?
So go ahead.
Essentially, again, the practical question is, most of our patients are on ARPI and they're going to become castrate resistant. So again, alluding to Ryan's point, do we just add this on as a kind of a salvage measure? Because it's very rare that the patient is not on an ARPI, right? So I don't know how to use this information, and except in rare patients where they're just on like Lupron or something, and
I understand.
just slowly, or the urologist send the patient over. They were just giving Lupron for years.
Yeah.
There are a lot of patients.
That could
like
be a patient like that, but
so that is the only patient where this data becomes valuable. But once, if the patient is starting their journey with a medical oncologist with castrate-sensitive prostate cancer, I think in 2025, all of us are going to put them on ARPI. So I don't know how to use that information.
I get your point. So basically, the patient selection is a key issue. So whether we are going to find the right patient population to go for this regimen. I think that's the challenge when we do the prostate cancer management in the community setting. So this is not a unique situation. Actually, this is quite common. How to collaborate with the urologist and then try to see those patients early enough, look at the whole big picture, plan out what we should go first, what's the next, how to sequence the treatment. So I think that's a very good point. And then unfortunately, as a community oncologist, we have to deal with that. We're not in the academic setting. We're not going to see every newly diagnosed prostate cancer patient. So sometimes we do see patients who has been exposed to a lot of treatment.
I think clinically my question would be that suppose prednisone, ADT progresses, would you say I'll use Enza plus radium as a synergistic maybe effect, or say that no, I don't believe in the switch in class and I won't go for this phase 3 study? So I think that answer I don't have.
We don't have the answer. The trial design is the patient has never been exposed to ARPI. But,
so it's going to be...
Yeah, theoretically speaking, ebialterin acetate is a CYP17 inhibitors, and then the others, enzalutamide, is a androgen receptor blockers. So they are doing something different. I think that might be the reason Dr. Babu's case, you're 93, 96 years old gentleman, has some room to improve, to work. But on the other hand, I think a lot of cancers share the same pathway. If you block the one, you pretty much saturated the effect with another one.
But there is data on this switch though. Abiraterone to ARPI switch, anti-androgen switch, it can work 25%, but not the other way. For some way, I don't know the exact reason behind that.
I think I would make a switch in patients, maybe if they're not chemotherapy eligible type of patients, right? Suppose I cannot just do docetaxel and I'm kind of running out of options, then I might say that, okay, let me try a switch. I think in those clinical scenarios, I might.
I mean, my patient is 5 years out.
No, you're trying to find a reason not to give chemo. I mean, try everything. And
in theory, I should not have given it because his Mayo Clinic doctor said, it's not going to work. But it's
that
like,
goes by data.
Yeah, this is like COVID shutdown time, 2020. I said, what is there to lose? We'll try. Boom.
I'm glad you have an opportunity to try, and then it works for this patient.